the studies that we've done, roughly 20,000 Americans are impacted each year. So a lot of neurologists or even ER doctors are often not aware to think about encephalitis as a possibility. So it's typically, well, you have a stroke or you have flu or whatever. So these people that are actually going through a very horrible brain experience get sent home from the ER or from the hospital because they don't think to check for encephalitis. So that is one of the main reasons that we're pleased that you're interested in this topic, because we need to think about it faster as a diagnosis. And I'll kind of get into that in a little bit in terms of the different causes of encephalitis so that you kind of get an understanding for it. But I'll just kind of talk first about our organization. And our mission is very simple. We aim to improve the life quality for those impacted by encephalitis. And that applies not just to the patient themselves, but to the caregivers, who often are the ones that are having to navigate and figure out, what's the medical jargon and why are they running this test or that test. Also clinicians, and I'll get into that too in just a second, about how we work with the medical community. And we also work with the general public and just trying to raise awareness so that it's thought of, instead of discharging these patients that need very critical medical care. What's not on the slide is insurers, and that is one of our objectives, is to work more with the insurers, because it's very often that a patient is denied the medical attention they need because of the lack of understanding on the insurer's part. So delayed treatment also delays the progress that the patient can make. So in the absence of that, we're looking at people that could lose jobs or get financially ruined, whatever, because they simply cannot participate in the world or in their job life or their family life the way that they had been before the onset. So we have a three-pronged mission that supports our, improving the quality of life. Part of that is the advocacy. So we have a hotline that we man. It's pretty much 24 hours a day, and it's also 100% free of services. So we don't want to penalize a patient or a caregiver for needing help when they've already had to come up with a lot of money that they may not have had in the first place. It's a very expensive illness. So our hotline supports people either in crisis, or they may have been diagnosed 2 years ago, 20 years ago, but they're not making progress. And so they're looking for help of what else can we do? What alternatives do we have? We also have support meetings. Prior to COVID, those were always in person. We're shifting to Zoom now and doing theme-based support groups. So they may want to talk about the etiology or cause of their encephalitis, or they may want to talk about a specific sequela or residual from their encephalitis, whether it's migraine or seizures or whatever the case may be, so that we can target groups that need to know a specific thing. Some of the one-on-one support we do is related to just how to move forward. So if you think about encephalitis, the basic understanding of it is it's inflammation of the brain. You think about meningitis, it's the outer layer of the brain. So it's the meninges that are between the skull and the brain. We often see meningioencephalitis, and so sometimes they have both issues. We were very focused on trying to serve one need before we expand into others. So we specifically focus on encephalitis, which is swelling of the brain. And often these patients have had, especially in the case of herpes virus encephalitis, they have a lot of frontal lobe damage. And so they may be very angry at their circumstances, or they may be frustrated with their doctor or whatever. So we try to help them on a one-on-one basis to prepare for doctor appointments so that they're presenting their specific need, and not just going in there to rant and rave and bash doctors. It's amazing how much of that happens, and you usually don't get the right outcome if that's your purpose, is just expressing your anger. So we work with them on kind of not just tempering their emotions, but also getting to understand what they really want to get out of an appointment. We have a large network of doctors that we can refer. We're constantly adding to this list. We have a wonderful medical faculty that has seen close to 10,000 encephalitis patients over their careers, and they do complex case reviews. On the research side, we are actively pursuing a study with the University of California at San Francisco. They have probably the best, I'm assuming everybody knows what CSF is, cerebral spinal fluid. They have the best sequencing technology in the US. And so we have given them 250 samples of encephalitis patient CSF fluids so that they can study that and try to understand more about the etiology or cause, because often that is unknown, and I'll get into that too. We also are supporting Johns Hopkins in a study about the long-term residuals that patients have. So fatigue and migraine, memory loss, or some of those things, but we want to do an actual study to be able to report back and have an actual study that says here's what we've seen based on the number of people that we were interviewing or participated in the study. And believe it or not, it was only, well, I want to say 12 years ago, there wasn't even a real definition of what encephalitis was. Like, what criteria had to be met in order to say, okay, this person has encephalitis. And so the medical faculty on our board, I believe all but maybe one of them participated in this case review to say, here's the definition of what it really is. And you have to meet these criteria in order for it to really mean that it's truly swelling of the brain. And we've done surveys. I'll show a couple of things there. The fun things that we do are, around the awareness. We love the advocacy part. We love the research, but really just, getting more awareness about encephalitis in the public domain is really important. So we've done lots of webinars. Of course, we have social media and website presence. We have produced articles. In several cases, we've met with hospitals. We had a great several opportunities to present our organization and what we do to neurology departments at hospitals, where the entire neurology department is invited to understand more about not just encephalitis, but also how we can help their patients in the future. Also, neurology students like yourselves that we have taken an actual survivor so that they can see the person. So it's not just a slide that you're going to look at and try to remember someday, maybe 15 years later when you finally see an encephalitis case, but you've actually interviewed and talked to the person and interacted with them so you can understand their experience and what they went through. And it just puts, I think, a better spin on understanding and learning about it. So that's, kind of what we do. I'm going to just pause for a second. I'd rather this be interactive. So y'all just stop me at any moment, raise your hand or yell at me or whatever, and just say, I have a question. But now we're getting into the meat of it. That's more about, who we are. But any questions so far?
You were going to mention some of the criteria, right?
Mm-hmm.
Okay, perfect. I was just wondering, but I'll wait for that.
And I'll see if I can grab that article. Some of them are protected under PubMed or whatever. But I think the case definitions is one that I can forward you.
Okay.
Anything else before I continue?
Yeah, I actually had a question. I remember you were talking about your hotline and how people can volunteer for it. Can you share the link with us just to see if any people here are interested?
Yeah, it's basically if you go to encephalitis411.org, I think on the very bottom of the page it's got the hotline number. It's pretty active. About 3 years ago, we were getting maybe one call every other month, and now we're averaging 3 to 5 calls a week as people continue to find us and the word spreads. But the phone number is, I'm going to try to do this by memory, 833-411-3350. And that's toll free, and it takes both phone calls and text messages. So we do a lot of text messaging as well to interact with patients or caregivers that are needing help. So we already talked about, what's encephalitis. It's swelling of the brain, very similar to stroke. It, like I said earlier, it impacts 20,000 Americans per year. We believe that is a very understated number. We think it's probably closer to double that number, only because it's starting to get more traction in the medical community and doctors are starting to recognize it sooner. So there is a study going on right now that'll probably be another year before we get the results to try to determine what's the actual number. But you think about Lou Gehrig's disease or some of the other cerebral palsy, things that people have heard of, they know it, yet it happens at a fraction of the rate of encephalitis. So that's part of our passion is, hey, this is happening a lot more frequently. And, 10% is a modest number in terms of who dies, but it's the long-term damage that impacts the families the most. So based on the type of encephalitis and how quickly they were diagnosed can really impact how they're going to proceed in life after the fact. It literally can strike anyone, anywhere, anytime. So when I talked about the herpes encephalitis, that is a lot of people think of it as a sexual thing. It has nothing to do with that. The herpes virus is in roughly 90% of the adult population in the U.S. It could have been a simple kiss from your grandmother when you were a toddler, when she had a cold sore on her lip, and it just passed on, and then it just continues. You pass it on to your children and whatever. So that is one of the ones that is most easily diagnosed, but it kind of underscores the fact that it can be caused by so many different things. But if you take that one instance of the herpes virus, it literally can be anytime, anywhere. And there's no study that has any conclusive results about why that is. Why does it, if 90% of the population has it, why does it only result in encephalitis in maybe 0.1% of the population? So there's a lot to be understood still about this field. So this is basically kind of if you look at the pie chart, the unknown, at least in the U.S., still is over 50%. They don't know what caused the brain to be inflamed. There's lots of explanations here. I'm going to show you a few slides. I'm going to just kind of roll through them very quickly. But if you don't know what caused it, you don't know how to treat it, right? So it leaves the doctors in a quandary of, okay, well, we got the CSF fluid. We know that the brain is inflamed. We have other results back from the MRI or whatever it might be that indicate, yes, that it's definitely encephalitis. But if we don't know what it was, what do we do? In some cases, you might treat them with steroids, but that could be actually fatal if you don't know the actual cause. So it makes it very complex, and I'll talk about that a little bit more too. Let me pause again to see if there's questions.
Yeah, I have a question actually. So I know you mentioned that about 10% of the patients actually die, but the other part of the percentage that don't die are affected long term. Can you speak more about that? Like what areas are they affected? Just the long term effects of it.
Sure. It's a great question. There's going to be a couple of slides that point to the typical onset symptoms, and another slide that points to some of the long-term residuals. So it really does vary significantly, some of it based on which areas of the brain were impacted. In the case of herpes or West Nile virus, I'm sure everybody's heard about, they have very specific patterns. So with the herpes virus, it can impact the frontal lobe, so you might see some behavior or mood changes. They typically have short-term memory loss. In the case of West Nile, it's often where they have mobility issues and speech issues. So it just depends on where it impacts the brain. In some cases, it impacts the entire brain. And so you're dealing with a global versus focal aspect of how that person is impacted and what the outcomes tend to be. Any other questions before I move on? All right, let's go. These are the ones I'm going to skip through pretty quick, but what it does illustrate is that there are so many considerations. So if you're an infectious disease doctor or a neurologist, these are just some of the viral diseases that could cause encephalitis. So I mentioned West Nile. There's also Japanese encephalitis that some of these are regional, right? So you can't get Japanese encephalitis in the US, but you can in Asia. West Nile has usually been in the Americas until the last, I want to say, just 2 years. And somehow it hopped the pond over to the UK. So it's becoming more prominent in Western Europe now. You hear about the anti-vaxxers, and I'm sure everybody has an opinion on that here, and I'm not going to vote one way or the other, but I'll just say that if you get measles vaccine, it's not a live vaccine, and it is 100% effective against the live measles if you come in contact with it. And 30 years ago, it was completely eradicated in the US. And now that we have some of the anti-vaxxers and it's kind of surfaced its ugly head again in the US, if you get live measles version now, it is 100% fatal. So we have to stand on a kind of a slippery slope where we advocate toward vaccines or not. But in this case of measles, it's one where we have a strong stance of, hey, vaccinate your kid, because if you get measles, let's just say at 15 years old, it may not surface as encephalitis for another 15 years, and it is 100% fatal. It's called SSPE, and I forget the name. There's so many acronyms these days. So there's a lot of things to consider. Rabies is another one that's 100% fatal. It's very rare. I mean, we hardly see it in the US. But again, it's one of those things that we consider. Some of these I'm sure you recognize, Ebola, everybody's heard of. So I'm not going to spend a lot of time on these. I just want to kind of show you there's so many things to consider. So when a doctor sees, okay, yes, it's encephalitis, they have to consider, well, which kind, And so if you go back to the last slide and then this slide, it can be fungus, it can be bacteria or parasites. And then you have the non-infectious causes, which are autoimmune. And this is an area that is really promising in terms of how much research has been done on it. It has just skyrocketed in the last 12 years. If you ever heard of the book Brain on Fire, this was one where a young lady in New York experienced a lot of psychosis, and they basically wanted to lock her up in a psych ward. And a doctor got just so focused on her case. It was so unique and interesting. He continued to study it, and he finally was the one that discovered anti-NMDA receptor encephalitis. And so that is being diagnosed at a tremendously faster pace than it would have 12 years ago or even 5 years ago. So that it's pretty well known now. There's also seronegative encephalitis, which means it's autoimmune, but they don't know what the actual immune cause is. So this is a frustrating one because it's kind of like not knowing what the true cause is, other than there's an autoimmune reaction. So it's harder to treat. So these patients spend a lot of money and a lot of time navigating the medical system, trying to figure out what do we do next. And that's a lot of the hotline calls we get are parents that are just, they want their child back, right? Their child went from being this academic person, straight A's and very active in either band or sports. And then suddenly they're just kind of, no emotions, lethargic. And, the parents are kind of like, so what do I do? And so there's a lot to be studied in that area. But we're glad that there's a lot of progress being made there. And then some of it, can be genetics, or there are cancers that can go into encephalitis as a result, and those are more rare, but they are there. So those last three slides, in terms of infectious and non-infectious causes, are just to kind of say, wow, the spectrum is so big, and there's so much to learn. And that's again why we're so passionate about it, is you have to consider all these things so that the patient isn't just left to die. So I'm going to pause there and see. I'll just kind of tag on to the autoimmune research that's been done. So if you look back to 1996, there were probably 5 papers or studies written on it, and if you look back just shy of 2 years ago, nearly 350. So it's really making a lot of headway, but we still have a lot of headway to do on the infectious or viral side as well. So this is a good stopping point to see what questions you might have now.
I have a question. So, because there's so many different causes, how long does it generally take for a certain diagnosis to be reached, if there is one that is reached?
That is a magic question. So part
Maybe
of it,
for the more common ones.
yeah. So on the more common ones, once they've determined it's encephalitis, they can look for specific patterns in the brain. There's also a huge intake of, what exposures have you had? Have you been traveling to other countries? Do you have pets? Have you been camping? Because it can be mosquito or tick-borne. So a lot of that data helps them kind of go, okay, they were in this country where these viral agents are present. And so let's kind of start to look down this path. And so they kind of funnel their diagnostics that way. Typically, if it's a known type, so if we go back up to that pie chart where I said more than 50% in the US is unknown. If you look in Australia, the unknown causes are only about 20%, because there's fewer viral agents that they're finding that actually causes it. And because of the research on autoimmune encephalitis, like this slide, they're able to look for that, as an alternative. But the presentation is very different. And I'll talk about that in a second as well. But it can be, and I'll show you a poll because we do a lot of surveys to understand our community better. The rare cases is 3 to 5 days to figure out the actual cause. But most of them are much longer, unfortunately. But I'll kind of caveat that with people that respond to surveys, kind of like the people that do a Google review, right? You're either really dissatisfied or you're really happy. And so there's that in the middle that they're like, yeah, I got diagnosed, and they don't care. They're not going to respond to a survey or whatever. So kind of have to caveat that with, these are the people that feel very passionately about participating, if that makes sense.
Yes, that does. Thank you.
Sure. Any other questions?
Yeah, I was gonna ask, since there's so many viruses that are causing this disease, how would you go for treatment protocols, or how would you provide people with supportive care?
That is another $1 million question. It's a good one. I'm gonna I'm going to address that if you don't mind in just another slide or two.
Yeah, I kind of had a feeling maybe you're gonna go over, but it's
I'm heading that way. Yeah, you're tracking with me. So, and I only put 18 slides together, so I'm not going to kill y'all with death by PowerPoint. So, some of the more common symptoms at the onset, I mean, it is so confusing for doctors because it can be all over the place. I've met people who had vomiting and diarrhea and huge, like 105-degree temperature, hallucinations where they were seeing flying fish and it looked like their arms were bleeding. So that's like one extreme. And then others who it was still a sudden onset, but maybe not as dramatic, where they went from, okay, it's hard for me to understand how to form words or how to talk, and gosh, why is everything so loud? And to where it's harder, it might sound like a really complex migraine in that case, where, okay, so theirs is not as dramatic. So it's that's one of the variables that can be so confusing, and probably why some people are dismissed or discharged from the hospital quicker, because it's not as dramatic and they're not thinking, gosh, should we run a spinal tap or a lumbar puncture or whatever. And then if you look at ongoing residuals or sequela, these are the most common areas where people have problems long term. I would say most of these apply to the viral or infectious type, and probably 2/3 of them apply to the autoimmune type of encephalitis. So, concentration, focus, very, very difficult. Most, if not all, suffer from short term memory loss where they carry a notebook or, have some type of memory aid, or they might text their spouse and say, help me remember this or whatever. Or they have sticky notes all over their house. Multitasking is very challenging for a lot of them, where they're just like, my gosh, I used to be able to talk on the phone while I was driving and eating a chicken nugget at the same time. And now, if I can just drive in the slow lane, I'm doing good. So, this is a visual that we've gotten a lot of positive feedback on from survivors who say, oh my gosh, I can identify with every single one of these. And it depends on what part of the brain was impacted, right? So if you look at the one on the top right that says the body temperature regulation, that can happen at the back of the brain, where the brain stem was impacted, and some of the just most basic aspects of what you don't have to think about. It's just how your body interprets information from the brain can be impacted. And also the olfactory senses, altered smell and taste. You keep hearing about that with COVID, right? And we get a lot of COVID calls on our hotline of people that, they had COVID, and then within a month or two, it evolved into encephalitis. So, every time people are filling out those questionnaires and it says, have you lost your taste of, or your sense of taste or smell? It's like, well, yeah, but it's not because of COVID. It's because I had encephalitis. So there's a lot of things to consider there, and you have to kind of decide, do I check the box yes, or do I just leave it as no because it's not relevant to COVID? So I'm going to pause there as well to see what questions you might have.
I have a question actually. What you just mentioned about COVID and encephalitis, I actually never knew that. I just thought that COVID just results in altered sense of smell. But now that you put it in this in this way about encephalitis, I think that's really interesting. And it made me think about, so my question is, so you mentioned that there are different causes, different viruses that lead to encephalitis. Is there one cause of encephalitis that is more serious or causes worse long-term effects, or maybe causes different set of symptoms? Or is it just encephalitis has the same set of symptoms?
That's a great question. So there's several answers to that. So In the case of herpes encephalitis, if they did not get the drug acyclovir within 48 hours, it's typically 85% mortality rate. So if a patient comes into the ER and they are presenting some of these issues, it's almost 100% that the doctors will just go ahead and give them acyclovir in the case that it might be that. We recently got a hotline call just maybe 3 days ago where the man died. It was 11 years later, but he was not diagnosed with the herpes encephalitis until day 4. And so, because the delayed treatment, and that's one of the only types you can treat, by the way. So, autoimmune can be treated, herpes can be treated, all the other viral, you're basically just treating symptoms. But that man had complications for 11 years and finally died of complications from encephalitis because he wasn't treated fast enough. With autoimmune encephalitis, it's often a tumor. It's usually females, and it's usually late teens to, I would say, late 20s, where there's a tumor on the ovary that is sending a misfire signal to the brain. And that is very treatable. They either remove the tumor, or maybe the tumor and the ovary. Men can get it too. It's not as common for men because obviously they don't have ovaries, but it manifests in different ways in different people. So I think I got part of your question. Let me make sure I get the rest of it. What part did I not answer?
I think you answered it. I think you answered pretty much what I was asking. So you said that the only treatable causes are the autoimmune and the herpes and encephalitis. And I guess the other part was, does the cause have different set of symptoms?
Yes. So with viral encephalitis, it's more likely to, it's hard to explain. So it's going to be more of your common symptoms that people have heard of before. With autoimmune encephalitis, it presents often as more psychotic, and the patient may be more reluctant to say something to a family member until it's just like completely obvious. It's kind of a slower onset, and it's very gradual in how it presents. And so finally it's like, okay, my gosh, something's wrong with my friend. She's dodging my calls, or she's not showing up for work, yet she was a very career oriented person. It could be that they're, seeing things that aren't really there, or hearing voices. And so those present very differently. So it's getting easier for doctors that are familiar with encephalitis to say, okay, this is definitely autoimmune versus, okay, this is definitely viral. And then you had mentioned COVID. So we just had World Encephalitis Day 2 weekends ago, and there were 2 presentations on COVID in the brain, and a lot of patients wonder, hey, I had encephalitis, should I get the vaccine? And that's been a big question of, is that putting me more at risk for something else, or is it going to actually help? And the conclusion from our medical faculty and other doctors that presented in this conference was, it's better to get the vaccine than take the risk of getting yet another illness that could develop more neurological issues. So unless they're being treated actively with like IVIG treatments, or other, especially autoimmune treatments, they're like, wait just maybe a month or 2 until after those treatments are over. But for the most part, they're saying just it's not worth the risk. Does that help?
Yes, thank you so much.
Any other questions before I move on?
I had a question. So for the herpes one, you said like you need to provide treatment like as soon as possible, and after a few hours, it is like 85% mortality. Is that the same thing for the autoimmune ones? Like, do you have a time limit where you need to actually provide the medication and then it turns into mortality, or you have like longer time period to provide the medication?
So it's a great question. For autoimmune, you have more time to work with. Herpes is, I would put it in its own category of the mortality rate and how quickly you've got to get the medication. That's the only one we know today. There's, like I said, there's still so much research to do. But with autoimmune, it's, recognizing it and then being able to determine what type it is. It could be specific to the limbic system. I mentioned the anti-NMDA receptor encephalitis. That one's very treatable. Most people that have that get treated, they'll still have some long-term issues. It could be, problem solving or memory or whatever, but they don't typically have the long-term effects that the viral patients have. Does that answer your
Thank
question?
you. Yeah, you did. Thank you so much.
Okay. So I'm just going to talk for a minute about what makes it complicated. So in most cases, there is no predicting factor. I met a couple. The man was a government security, very high level government official, and he was traveling to another country. And before he left, he didn't feel right, and so he went in. His doctor said, "Oh, it looks like you probably have a sinus infection." So gave him antibiotics. It was a very long flight. He lands. He doesn't know his name. He doesn't know why he's there. He doesn't know his job is in the CIA. And he was held in that country for 2 months. The family flew over, and there were so many complications. He comes back, and he died within 5 months. This is one of the sad cases that we consulted with, and the predicting factors were so benign that it did not tip off his doctor that this could be something bigger than a sinus infection. It was primarily headache and some memory issues. So, you typically don't see somebody like, let's just talk about stroke, right? You can see somebody's blood pressure getting higher, 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 higher. We got to do something, right? With encephalitis, you don't know until the onset, just boom, it just blasts you out, right? Imaging, oh my gosh, I could talk about this for an hour. So I'll just be really quick and say that imaging has a long way to go. You can literally have somebody in a coma from encephalitis for 2 full months. They don't know their family, they don't know their own name, they don't know what year it is, but their MRI comes back completely normal. How do you explain that? It just is so bizarre. But there are often patients with very severe cases where the MRI is completely normal. It's part of why they rely on the lumbar puncture or spinal tap. The presentation of the illness, like I said, with autoimmune, it can be, more psychotic behavior. With viral, it's just kind of all over the place. So it's again why we try to do more education. Other than the autoimmune disorders, the research and studies, they just need more attention. And the way our organization formed is actually kind of an interesting story, because the doctors that are part of our medical faculty, they would meet each other at neurology events or infectious disease events, and they always found each other. And they were always like, "Hey, I got this case of encephalitis, and I don't know what to do with this guy." And they all started working together, and there were literally 85 doctors around the globe that were part of a consortium. And they had invited me as part of that, as well as a couple other folks, and kind of said, we got to do something about this. So again, we're just focused on the US, but we still interact a lot with our international colleagues to just try to put more of an emphasis on the research. But our doctors are invited to speak at most national and international events because they've studied thousands of cases, and they realize there's a real unmet need for helping further the study in this area. So this is one of the studies that we did, or one of the surveys. So we asked people, how familiar was your doctor during the diagnosis phase? Because we want to understand, are we just hearing a lot of, background noise that people aren't getting diagnosed fast enough? Or is this real? And so as you can see, this was 306 people that responded. Only 28% got diagnosed within 3 days. That's horrible. We have so much work to do. And you look at the rest, and, familiar and somewhat quick was 21%. But if you combine the, delayed diagnosis because they had to see so many different doctors, or weeks plus months, and in some cases years, it's roughly 50%, right? So that's, we have a long way to go. In terms of diagnostics, MRIs and CT scans are most common. They're looking for, heavy scarring similar to a stroke. We've talked about lumbar puncture several times. Seizure is probably common, and I would say at least 60% of survivors. And so y'all probably know what EEGs are, right? They're looking for seizure activity, right? Okay, so that's a very important study to do. Of course, you have to catch it, while it's happening. So sometimes people will do a 3-day EEG, or even, a couple of weeks, just so that they can capture that seizure activity. You can also do, blood and urine tests. Neuropsych exams are typically not your first go-to, but in the cases of autoimmune encephalitis, might help them indicate where some of the activity is occurring in the brain. It's most helpful in the long-term kind of, okay, what do we have to work on now? We've established that you have encephalitis, but now we need to understand your deficits so that we can treat you better. And that might say, hey, your short-term memory is awful. Let's do these things to focus on that. And in other cases, it might be, hey, your math blew up, and so you either need to change jobs to where you don't have to use math as a basic function to continue your job, or let's focus on how we get that better. In the case of math, often it's because the person can't hold the numbers in their head long enough to do the addition or subtraction, even if it's very basic math. It's very rare that you would do a brain biopsy. That is like, you've exhausted everything, and then you're like, okay, we still don't know. But typically this person is seizing so extreme, like 30 seizures within an hour, that you finally say, all right, let's just get them under control. You may even induce a coma so that you can calm them down long enough to get that brain biopsy. And then in terms of the team that it takes, it's a pretty big team in order to get the right care. I wouldn't say that this list is representative of most people. A lot of people, they're sent home, they're like, yep, your brain's no longer inflamed. And I'll just take that for just a second. The acute phase, where the brain is actually swelled, is anywhere from 5 days to maybe 2 weeks. It's not like this is a lifetime sentence where the brain is always inflamed. The acute phase is relatively short, typically less than 2 weeks. But where you go after that, always need a neurologist, and that's one of the teams that we're trying to educate the most, because we find that that's where a lot of patients and caregivers are kind of failed, is because they're used to treating strokes and seizures and things that are very common, right? And it's not as complex. So there's a lot to do in that field. Psychiatrists are very helpful in managing medications, as well as working with the autoimmune patients. We highly recommend getting a team of rehab specialists, whether it's occupational, speech, whatever type of therapy. And most people deal with the what we call the invisibility of the disease. And so a psychologist is very necessary, because most people lose their identity. They used to be this active, I'm going to, run 5 miles a day. I'm going to work 80 hours a week. And suddenly, if they can put in 20 hours a week at work and me even just walk around the block, it's a good day. So they lose their identity, and a lot of people can't understand because they can't see a lot of the residuals. So if you think back to that slide a few slides ago, you can't see dizziness, you can't see high blood pressure, you can't see migraine, so the people kind of feel lost. So the survivors can really hit a depression mark that we try to avoid. And that's why we recommend that the psychologists be a important part of the team. And I think this is my last or next to last slide. And I'll just say, the treatment plans are still very hit and miss in terms of the doctor's knowledge or the family's resources, to understand that they need more help. And so most people you'd see on the green side of the pie, they were just left on their own to figure out their own treatment plan, and that's not cool, not appropriate. And 20% had a month or two of treatment. And the exceptions are those that had a very thorough treatment plan. Those typically are the ones that were so dramatic at the onset that you just couldn't ignore all the symptoms. So we're trying to work on that purple and green side of the pie. I'll just speak briefly on brain plasticity. If you look at the MRI image on the right, this is a case of Rasmussen's encephalitis. Rasmussen's is a very rare type of encephalitis where they literally, because the person is seizing so frequently, they literally have to remove half of the brain. Can you imagine removing half the brain and still functioning? Because the left brain and the right brain do so much different things, right? But that's the only way to control this. I have met one Rasmussen survivor, and he is in his mid-20s, and he has been able to move out on his own. He lives an hour away from his parents, much to their chagrin, and he holds he maintains a job. And it is amazing how brain plasticity works to overcome that whole other hemisphere of the brain that's missing, and it is able to rewire itself. The other image is, because I'm in the Dallas area, I thought this would be an image I could use. So if you look in the center of the slide, this is 635 and this is 75. And you see there's, traffic jams right here. So you kind of want to avoid that intersection. So if you think about encephalitis, basically that part of the map blows up and you don't know how to get through those intersections anymore. So you have to find all these little side streets and go, well, I have to get up to Richardson, but I can't go this way because there's, bad traffic and my brain doesn't know how to comprehend that intersection anymore. So I'm just going to take all these little side streets and I'm going to make a new path. And that's kind of the way the brain works with brain plasticity. So it's kind of rewiring itself. A lot of people have to kind of rest for the first few months, and then that rewiring starts to begin as the brain starts to heal and recover. So it can go, oh, okay, let's take some side streets because I don't know how to find my way on this map anymore. There's tons of apps and games for smartphones that people use now. And there's also a big difference between adults and children. Children are, you just think about the learning process. When you were 5, you didn't know what a 12-year-old knew or a 20-year-old knew. So, the brain is plastic through that aging cycle. For an adult, you've kind of hit that peak. And so the recovery process is a little bit tougher because your learning process is kind of stagnated over time. And the last, I'm just going to cover caregivers. They are under so much stress. And so we kind of use the analogy to the flight, take care of yourself before others because you're only as good as what you can give your loved ones. So we encourage them to get in support groups so that they can talk about, the stress that's been put in their lives. Often their loved one couldn't go back to work, so they're suddenly the breadwinner and the caretaker, and nobody trains for that, right? So we just try to encourage them to take care of themselves, do things that help them, whether it's yoga or massage or whatever, and ask for help. Often they are just too much pride or embarrassment or whatever you want to label it, to ask for help. So that is it. And I welcome any other questions. I appreciate your questions so far and your attention. I see a hand up. I don't know.
Oh, it's a little clapping.
Oh, okay.
Applaud.
And the people went wild.
Thank you so much for accepting this. I really liked it, and I personally feel like I learned a lot, especially
Great.
yeah, because I was interested in it, but I definitely didn't know as much information as you gave us. So thank you so much. And if anyone have any questions.
Yeah, just another comment, like it was very eye-opening. I've learned a lot of things that I haven't heard before. And so I think you're doing a great job. I think Encephalitis 411 is doing a great job spreading awareness. And yeah, just a lot of things that I've also learned has been really surprising as well. And so I hope to see further advancements as well. Thank
Great.
you.
Well, I appreciate your attentiveness on a Friday night. It's been great hearing all your questions, and I'm glad you learned some things.